Oh, hello. It is me, and it's Jonathan Staiano here, and I'm live, and I am here to answer questions that have been asked of me, and I will also be more than happy to ask any questions that happen to be um, posted during the broadcast. I will keep an eye out for them, so by all means, post away. But we've got some questions that have been previously submitted. We've answered these questions individually, but I thought I would bring it up here just to bring it out to a wider audience. So the nose scar technique for inverted nipple correction. The question is, do we do this is an inquiry from a patient in London. Do we do the nose scar technique for inverted nipple correction? Because she has heard of it. And the answer is yes, we do. Yes, we do. It's not really, I mean, the thing about plastic surgeons is we try to hide our scars. Now, most of the stuff that we do creates scars, but we do some things that we do, really the scars fade so well, it is really impossible to see. An inverted nipple correction, is in that category. The scar, there is a scar, so strictly speaking, I guess it's not a nose scar technique, but the scar is at the base of the nipple. Now, when you have an inverted nipple, obviously it's either flat or actually there's a sort of hole or crater. So you make the scar at the base of the nipple, which will be everted, so which will be the mountain. So you make it at the base of the mountain, and you also make it at the 6 o'clock position, so the blind side, so the patient can't see it. And it's just a little stab incision, because the best way to correct inverted nipples is this, which is by making this little stab incision at the base of the nipple and then dividing the milk ducts. Now, it does mean you can't breastfeed, so that's the big thing. Do you want to breastfeed in the future? Now, you might not be able to breastfeed anyway if you have inverted nipples, but you might be able to. And so if you really wanted to be sure that you maintain the possibility of being able to breastfeed, then wait to have your children before having inverted nipple correction. Or there is a technique where you can leave the ducts intact, but that's more scarring. That creates a scar on either side of the areola. So that is not this nose scar technique. It's more scarring, leaves the ducts intact. But the problem with inverted nipple is often that the ducts are fibrosed and the ducts are putting the nipple down. So if you leave the ducts intact, there's a much higher risk of recurrence. There's a higher risk of recurrence any way you do it. Well, not the high risk. There's a risk of recurrence any way you do it, but there's a much higher if you leave the ducts intact, much lower if you cut the ducts. So the best way to do it, both in terms of low recurrence rate and low scarring, is to little incision at the base of the nipple and then divide the ducts. The problem with the London, we've got a clinic, we've got Paul Tully in London, who's a colleague of mine, plastic surgeon, who is at 152 Harley Street in the London clinic. The problem with the London clinic is that clinic is got lots of surgeons working at that clinic, and so it doesn't have in Edgbaston. It's my own. It's my building, and so two things. First of all, we have the see and treat. We have the minor ops room upstairs, so we can do a see and treat, which means we can see you and treat you on the same day as your procedure. And secondly, because we've got the minor ops room upstairs, we can do it very simply and easily under local anaesthetic in the minor ops in the minor operating theatre upstairs in Edgbaston. Whereas when you come to when you come to London, we go to main theatres, and we don't do the see and treat for inverted nipple correction in London. And because it goes to main theatres, it is more expensive. One of the good things about my own clinic is that I have my own operating theatre, so I don't have to pay a hospital for their operating theatre. So that is that's one of the benefits of the Birmingham clinic for inverted nipple correction, although we do other things in the London clinic, and certainly all the other breast augmentations and reductions and stuff, we can do it in London. So yeah, nose scar. So yeah, we do the nose scar technique. Well, as I say, it's a minimal scar, but that's the I mean, there is a way without doing a scar, and that's the nipplet. So I always tell people if they are have an inverted nipple, it's worth trying the Nipplet, which is like a suction device. You can get it in the chemist, and sometimes it can help, certainly with early inverted nipples that come out. There's different grades of inverted nipples depending on whether they sometimes come out or not. So if they sometimes come out, then you might be able to stretch those ducts with a Nipplet, which is a little suction cup. So that might be worth trying first. That's a truly no scarring technique, but certainly when it comes to sort of surgery and a more definitive treatment, then the best way is to make that little scar at the base. But as I say, you cannot see it once it's all settled. So thank you very much for that question, and the answer to that is a resounding yes. Next question was, we've got the nipple low on breast reduction. Oh yeah, tattoo. Yeah, lots of areas of bodies. A huge variety of tattoos. We've had the pleasure of having inquiries from, and a great range. Interesting, very interesting. So range. Well, basically we've got the someone with a big sort of sleeve, including dorsum of the hand. I can't do anything for that. With these sleeves and these big ones on the shoulder and things, I can't really. I've got to pinch the skin, I've got to cut the skin out. So that's sort of pretty much, I can't do anything for it, and that's laser or cover up, or I don't know how you do a cover up, but surgery is not an option for the very large areas of tattoo. And then interestingly, we've had another two quite interesting tattoos. A very small one on the finger. This is often the way that patients will get tattooed on the finger, and they're quite small tattoos. And you might think, I'd like to get rid of that. And then a quite big one in the sort of groin area. And the paradox is that the big one in the groin area is a lot easier to remove than the small one on the finger, because again, you've got to pinch your skin. And one of the problems with the finger or the hand, you might sort of pinch your hand, so the back of your hand saying, I've got loads of spare skin. Yeah, get that out, no problem. The problem is you've got to make a fist, and when you make a fist, all that spare skin disappears. So if you make a big, think, I'm going to cut that big, thing out of the hand, and then you make a fist, the wound will open up. When we're making cuts on the hand, if you're making a cut on the finger, you would probably do it in a longitudinal way, so that there's no tension on it when you make a fist. The tattoos on the fingers, often on the ring finger, are in a sort of horizontal direction, so they're going the wrong way. Obviously, you have to cut them out in that horizontal way, so they're going the wrong way, number one, so they'll be under tension when you close your fist. And number two, there's not a huge amount of spare skin on the finger, so even though that's a really small tattoo, and this one on the groin area is huge, the one on the groin area, most of it will come out, if not all of it, might come out in one go. Might need 2 goes, but you can get a huge amount of skin, particularly if you've lost weight, because that's the tummy tuck thing. You look at how much skin you get removed on a tummy tuck, because there's redundant skin. So if you have lost weight or had children, got some redundant skin in your tummy, then so much the better as far as I'm concerned, because I can take a bigger piece of skin away and close it up. So the big one on the groin is a goer, is a good one. The one on the finger is not so good. So the one on the finger, I'm thinking at least 2 or 3 goes, even though it doesn't look very big, because I couldn't get it all out in one go. And the other problem when you take tissue out from an area which hasn't got much tissue is you can get a little dish. I sort of call it a shark bite. The dish in the skin, and you might sometimes get little bumps on either end, which are the dog ears. You try and make them as small as you can, but then that makes the scar longer. You don't want the scar going too long. So the one on the finger is quite tricky, actually, and it's not uncommon to get that request. Often I think people get tattooed on the ring finger, and it is a tricky one to fix. So that's a good bit of paradoxical tattoo. I'm just swiping. Don't mind me. It's paradoxical tattoo queries there. So thank you for all those tattoo inquiries. Those 3, I think, demonstrate them quite well. Then we've got the nipples low after the breast reduction. So this is a patient of mine. I do have patients who I have to do revisions on, and who maybe haven't got 100% a perfect result. I think I have spoken about, I'll happily speak if you've had surgery elsewhere, and sometimes people who've had surgery elsewhere will come on here and ask for my opinion, and that is great. But I think sometimes people think, you don't have problems. Well, I think the fact of the matter is, anybody doing surgery will have things that aren't 100% right, and sometimes we need to do revisions and what have you. So, and I'm certainly in that category. I wouldn't say that I don't get any problems. I wouldn't say that I don't get any complications, because I operate, and therefore I do. Anyone who operates does, and that is one of the Downsides to the otherwise glittering glittering lifestyle and glittering job, it is one of the darker, more difficult bits to deal with. But anyway, I don't want to get too... so basically, this patient has had a breast reduction and saying, well, my nipples are right, they're sitting a bit low. And the bottom line is we need to go over it in the clinic, but I said I would mention it tonight because it is an interesting point. And not the main thing, but one of the big deals about doing a breast reduction is obviously the position of the nipple. When you do a breast reduction, it's the same as a lift, and it's the same deal with a lift. Breast reduction or a breast lift, you're moving the nipple. The nipple's in a low place, you're moving it to a high place, as well as tightening the skin. That is the point of the surgery. The real bad error that we all are very, keen to avoid, and if you see the error, you think, oh, eek, is when you put the nipples too high. Nipples too high on a breast don't look good, particularly if you have the nipples coming up past the bra. When your nipple is visible with the bra on, that is not a good look. And when you get something called pseudotosis, so you have a nipple that's high and a breast, the breast sort of looks weird, it looks droopy, but it's not droopy, it's because of the position of the nipple. So it's a bad look when a nipple's sitting high, and something that I particularly, and I think most people who are doing lifts and reductions, is very keen to avoid. Now, when a nipple's sitting low, I can understand why people, particularly if you've had a breast reduction, you think, oh, I want my breast to be more perky. I can understand that. Now, the good news is it's not that difficult to make a low nipple sit higher, as opposed to making a high nipple sit lower. So if your nipple's too high, that's a difficult problem to fix, because if you want to lower the nipple, you're going to leave a scar where the nipple was, and particularly if the nipple's visible in a bra, then you're going to have a scar visible when you're in a bra. So it's a bad situation when the nipple's high. When the nipple's low, you can raise the nipple, just to sort of another mini lift really, and just put the nipple in a higher place, straight line going down from it, which will already be there, because in a breast reduction there's already a scar going straight down from the nipple, so it's not that difficult to raise the nipple. The problem, and the thing that we need to delve into and get down to, is what is the issue. Is it simply nipple position? Because particularly in this patient, the geometry of the breast is good. The nipple position, in my view, is fine in keeping with the geometry of the breast, and I don't want the nipple to be out of the geometry of the breast. I don't want it to look wrong. And often what happens with a lift and a reduction is when you first have it done, the breasts are up here, and then they settle to what I call a more natural shape. And I try and make it show people photos of this pre-operatively, because it's always better to have these conversations pre-operatively rather than post-operatively, to say that the breast will settle to a more natural shape with less fullness in the upper pole. When people first have surgery, sometimes they think, oh, I love this is great, this is just what I wanted, and I'm thinking, oh crikey, it's going to settle. Sometimes people think, oh, I look a bit fake and I look a bit strange. Whatever you think, it settles, and it settles to what I call a more natural shape, which is concave in the upper pole rather than convex in the upper pole. And if you want to have a convexity in your upper pole, that is only really achievable with implants. You can't achieve that with your natural breast tissue. You achieve it when you first have the lift or the reduction, because you push all the volume up north, because we're always working against gravity, but then gravity always wins, and so it settles to that concavity, and that it is actually a natural shape. But some people think, oh, you know what, I had a lift and I had a reduction, I wish it was fuller. Now, so that's the thing you've got to get around. Is it the actual nipple position you're worried about, or do you think, oh, my breasts are a little bit not quite as perky as they were? Because if it's the perky thing, you can put the nipple higher up on the breast mound, but you're not going to change the shape of the breast mound, and you certainly don't want the nipple going up onto the pointing upwards. If the nipple's pointing down or forward, that's okay, but if it's pointing upwards, then that's not where you want it to be. So that's something you've got to be really careful of, and I think you'll be really careful raising a nipple. I've got to be really careful because I don't want to raise it too much. So nevertheless, we can certainly speak about it, and I'll be very happy to raise the nipple, but I've got to give that rider to say, look, I'm not going to make the shape different, because the shape will always settle to that shape, and I think it's a good shape and it's a natural shape. But I understand how sometimes people think I want more fullness, but that is difficult to achieve without implants, and I don't for a minute think that we should be using implants for that reason. Sometimes we say, I'll have implants, and no, don't have implants just to get fullness up there, because at the end of the day you can wear a bra, you can wear clothes, push your breasts up, because all these things we're talking about are out of a bra. Obviously the nipple position is not so much of a problem in a bra because you can't see it. So all these problems we're talking about are out of a bra. So in a bra you can push the volume up and do what you want. You might say I spent a lot of money on surgery, so I want to look good out of a bra too, which is perfectly reasonable, and if I can make it look good out of a bra, I will. But it's just one of those ones where you've got to be a bit careful what you wish for, because you don't want to push you into a bad situation with the nipple in a high position, because then it's very difficult to lower it, or at least it's very difficult to lower it without leaving a scar, and it's it's a bad place to be. I'd much rather be in a low nipple scenario. Ideally I'd be in an ideal nipple scenario. That's what I'm always looking for. I'm always aiming for an ideal nipple scenario, but if I miss the ideal nipple scenario, I want to go low, not high. That's my view. That's where I am. So I am. You're not trying to tell me that there's no live questions. Come on, guys. We had some live. Oh, sorry, I don't know what I'm doing really here. We had some live questions the last 2 weeks. I thought, this is 2018. We are here. We have landed. We've got a live, proper, full-on, live, interactive. What's that little comments button do? Oh, I can write a comment. Oh, I think. Would you know if I wrote a comment? Can I write my own question? No, you'd probably sniff me out. It'll probably say it was me. Can't get away with that. Anyway, that's my questions for the week, and they've been corkers. I'm sure you will agree. I'm looking forward to doing the same thing next week. I can't tell you how much I'm looking forward to it. So let's get some questions in, guys. Get some questions in. You can get them here on the Facebook. You can email Emma, not Laura. Who said Laura? Laura's went before Christmas. Emma at stayonaplasticsurgery.co.uk, or you can Facebook me or tweet me or do whatever you want in a social media type environment way to get hold of me, and I will look forward to seeing you in the same time next week. Be there, 7 p.m. And get the podcast and the YouTube channel. We're on a YouTube. We're YouTubing all these back issues, and we're podcasting them all. So if you're a podcaster, get onto iTunes and get it down here. And also we're getting an app. So actually the app is out on Google Play with all these YouTube videos and all the podcasts on it. But it's the App Store is a bit of a struggle, which I won't bore you with now, but it's proving to be a little bit more difficult. I am an Apple developer. Thank you. I do have an Apple developer account. So YouTuber, Apple developer, plastic surgeon, you name it. I've ticked those boxes. So enough of my rambling. I'm going to check out. Bye.